nursing quality and the magnet process and how that works in an environment focused on quality. So I'm just going to talk a little bit about quality improvement in healthcare, how nurses are improving practice around the world, and then, as I said, a little bit about our experience. So what is quality improvement? I always like this some from the writings of a real quality improvement guru from the United States, Dr. Brent James. He says that quality improvement is nothing more or less than data-driven problem solving. And you know, when you think about it, you really can't improve anything that you can't measure, because you won't know that you've made an improvement if you can't measure it. I also like to think about defining quality by understanding our patients' suffering. So this is a framework put forward by Dr. Tom Lee, who was actually in our Partners Health System for a long time, and now is the president of Press-Ganey, a patient satisfaction survey arm. But he talks about, if you think about patients and their suffering, there's disease-related and treatment-related suffering that we work all day, every day. All of us come to work in our various roles to really mitigate that as much as possible. And then there's this area called system-related suffering. And this, although the disease-related and treatment-related suffering is not completely preventable, his theory is that system-related suffering is avoidable suffering, and this is the area where we can have an impact. So what is avoidable suffering? We talked about it in the previous conversation about interdisciplinary teamwork. Failed communications among providers that results in either an error or incomplete communication or care of the patient can be avoidable suffering. Failed communication between providers and the patient and family and caregivers. Do we really know, do we really check back with those patients to make sure that they've understood what we've been telling them? Do we check back again because we know that when they come to us, they're so anxious, they have so much going on? And do we just say it once and go on, or do we just continue to check back? Underuse, overuse, or misuse of services, procedures, or therapeutic agents. Other areas of avoidable suffering, flawed or cumbersome tools, including some of our supposedly great electronic medical records that can sometimes make life more difficult. Other IT infrastructure issues, unnecessary exposures to a variety of things, flawed diagnostic or treatment decisions, and delays in diagnosis or treatment. These are all system-related sufferings that we can impact. And so the aim really of quality improvement is to reduce that avoidable suffering that is due to dysfunction in the care delivery system. So in nursing, we have a long history of using data to improve quality of care. The mother of modern nursing, Florence Nightingale, was really used data she studied hand hygiene, airflow, the nurse-patient relationship, and the hospital environment in general as she cared for patients in the Crimean War. And actually, in documenting mortality rates and studying them, she was able to demonstrate that the mortality rates in the hospital where she was caring for patients was really relating to infections that the patients were acquiring once they were admitted. They were not dying of their battle wounds, they were dying of the infections that they acquired in the hospital. So through her interventions in airflow and a variety of other things in the hospital environment, she was able to really impact mortality rates of soldiers in the Crimean War. Whoops, let me hold off for a minute. So this is a video that I want to show you. I love this. It was put together by a company, Johnson & Johnson in the United States. You've probably heard of them. They make a lot of products. They love nurses, and they are constantly doing work with us. And so this is a really short clip that shows you how nurses are impacting and improving the lives of patients around the world.
During the Crimean War, more soldiers died from infection than in battle. Until a nurse introduced sanitary practices still in use today. When the scourge of polio hit the world, it was standard practice to strap down and immobilize patients. Until a nurse discovered that movement and physical therapy had far better results. In the 1950s, jaundice was a leading cause of infant death, until a nurse found that a few hours of sunlight could actually cure the condition. At the dawn of the AIDS epidemic, no one knew how the disease spread. So patients were kept quarantined and alone, until nurses defied convention and embraced them with compassion. During the Ebola outbreak, the disease was thought by many to be too contagious to treat, until a student nurse used what she had on hand: garbage bags and duct tape, to protect herself so she could care for others. And cerebral palsy robbed many patients of their ability to speak, until a nurse gave them back their voices. And I will always be grateful to her.
I always get tearful watching that movie. I think I've seen it, I don't know, a million times. But you get the picture that we in nursing, I think the truth is we've been impacting care around the world for a very, very long time. What we haven't done, and I think that's where we are now, we haven't always measured the impact of our care. And so that's what we're going to talk about now. And that's what the magnet process is about. When you think about our domains of practice, we really are about the science of caring. All of the models of caring are developed by nurses. We are involved with others in the protection and promotion of health, prevention of disease, the patient and family experience of care, and the patient education and understanding of their illness, of their treatment, their medications, and whatever, so that they can become as self-sufficient as possible and increase their ability to care for themselves. So this is really what the magnet designation, magnet process has been concerned with over the last many years, and I talk about now how it started, but really what today this magnet process is focused on is helping nurses in hospitals around the world to really measure and document the outcomes of their practice. So what is Magnet? It is a voluntary credential. It is conferred by the American Nurses Credentialing Center, which is a subsidiary of the American Nurses Association. It is the highest recognition for excellence in nursing practice and healthcare delivery in the United States. And I say healthcare delivery because some people are confused by this. They think that, oh, this is just about nurses. We don't practice in a vacuum, as you all have been saying since I arrived, where we are part of a team. And so you can't really have excellent nursing practice if you don't have excellent clinical care in an excellent environment with excellent administration and excellent nutrition and pharmacy and social work and psychological services, etc. Only about 8% of hospitals in the United States have achieved this credential, and there are a few hospitals around the world that have also achieved the status, one in Canada, Lebanon, Australia, Saudi Arabia, and Belgium. The background is it began it came out of the nursing shortage. We had a very significant nursing shortage in the United States in the 80s. And at that time, the American Academy of Nursing appointed a task force to study the hospitals around the country that were clearly retaining nurses despite the shortage. They could recruit them, and once they recruited them, those nurses stayed and didn't leave their hospitals. And they wanted to understand what was it that was, what was the magnet that was attracting these nurses to these hospitals, and what differentiated them. So the key findings from those studies were that these hospitals had certain things in common. They had a very strong support for professional development of nurses and other clinicians. They had high levels of staff empowerment or shared governance. In other words, the voice of the nurse was at the table when decisions were made about how to allocate financial resources and other resources. The nurses in these hospitals had access to their leadership and could bring forward their issues and concerns. You see the sort of threads the same around the components of high-functioning teams. This is this kind of environment that's inclusive of everyone, no matter what level of the organization you're practicing. A lot of support in these hospitals for autonomous clinical decision-making, job satisfaction, very high nurse-to-nurse and nurse-to-physician relationships. And really, the more they've studied this, measurably better clinical outcomes. And those findings way back in the 80s are still the same attributes that you find in magnet hospitals around the country. So as a result of those studies, the Academy of Nursing then asked the ANA to create a mechanism to recognize these organizations for providing the excellent care that they were providing. And so they developed these standards that continue to be revised and improved. And in 1994, the first hospital, University of Washington Hospital in Seattle, was the first hospital designated a magnet hospital. So now I'll talk a little bit about our experience with magnet at Dana-Farber. We have been a magnet institution since 2005. You have to re-credential, re-designate every 4 years. I'm very proud to say that just this past week, we received our 4th designation. So when we think about improving quality, we think about leadership, always setting the tone, articulating a vision, inspiring the team. And again, this kind of a tone for respectful, professional interactions, and then a practice environment that is safe in the full sense of the word, safe in terms of ability, the proper staffing to take care of patients, safe psychologically, an environment that really upholds a fair and just culture, that we believe that people don't come to work to make mistakes, and when they do, we don't necessarily, it's not a punitive situation. We want to learn from the mistakes rather than punish people for them. And then, as I was saying, we really want leaders to support a practice environment of shared governance, where all nurses and all clinicians have a voice at the table. The practice environment, I think some of this is a little redundant, teamwork, relentless focus on safety and quality, continuous focus on learning and improvement, transparency in all things at all times, and then safe, metric-driven staffing, and then a real balance in the staffing between novice and expert nurses. Our practice, our nursing practice itself is all evidence-based. We are guided completely by professional standards, and we focus, we have very strong focus on error mitigation and prevention. We continuously try to measure what we do. We have forums where we are giving peer-to-peer feedback in that sense of teamwork, and always trying to improve care and the patient and family experience. So I'm just going to give a couple quick examples of some of our quality work. When we decide that we want to improve some process, we first and foremost measure where are we now? What are we trying to improve? Where are we? And where do we want to be? And then we set a target. And then we develop interventions and try to see how those interventions are changing our performance. And we continue to monitor, and we try some things and they don't work, and we try something else, and we keep measuring, keep evaluating. So here's one example, and I know my time is running out, so I have 2 or 3 here. But just to show you, and this is what the magnet standards require, and it really helped us and many other organizations to really focus on, be rigorous about starting with a baseline measurement, figuring out what our interventions are, and measuring our performance after. So this is called our Good to Go project. We identified a problem in our adult infusion between pharmacy and nursing and infusion that the pharmacy was catching quite a few, we call them interventions, but near miss events before the drug left the pharmacy and was administered. But problems with the orders, it just varied, a lot of different things. But 9 near miss events was a lot for this one area. And so we thought, what can we do to mitigate that? How can we work together as a team? And so we developed, the nurses and pharmacists together developed a checklist that before a nurse has to release orders for chemotherapy in our system before the pharmacy can mix. And so we developed a checklist to make sure, even though our nurses were doing this, but they would miss something. And by instituting this checklist, it helped them be sure that they had checked every single thing that needed to be checked about that order. And so over time, after developing the intervention, educating the staff, you can see that it has gone down. It went down to 4, it went up to almost 5. Now, then it went down to 2.8, and it's pretty steady at that low to 1 to 3 events and in a month. And it's really, or in a 6-month period. And it's been a very important safety and improvement and collaboration across teams. Another example here is in palliative care, and in one of our satellites, okay, my time's just about up, so just a couple more really quick. We were trying to increase the referrals to palliative care, and in this satellite, our new patients were only being referred at a rate of, you can see here, 1.7, 3.7% of our new consults, and we really wanted to improve that. We knew that there was an opportunity, and so through an educational intervention with the nursing staff around screening patients and families and really starting more dialogue about the benefit of a palliative care consult, they were able to increase that, and that has continued as well. The central line infection rates reduction, this was a big project in pediatrics. On the left, you can see we had a problem with these rates, and the intervention that we applied was a standard set of educational materials for the patient, for their family and caregivers, their parents, and across we implemented it in the inpatient and the outpatient so that the education was reinforced, the same interventions across the board. We've reduced that CLABSI rate significantly. We keep working on it. This is a huge area of risk for us and an area of constant vigilance. For the sake of time, I'll skip over this, but this is just what one nurse did in the community with organizing other agencies and so on to increase the vaccine rate, HPV vaccine rate in children in our state. Falls is another area that we work, of course, is a big area that in inpatient settings, but also ambulatory settings is a big risk for patients, and really standardizing our approach to patient and family education around asking for help and helping them understand their risk for falls has really helped us there. And then finally, we keep a dashboard in our nursing department of the key indicators that we're tracking. There's certain things that we track on every unit at all times, and it's sort of a snapshot way of seeing how we're doing every month. And it changes, some things change, some things stay the same. But that's it, thank you. I hope to receive some of you in Boston sometime, anytime. We love to have visitors, and I thank you for this time and your hospitality here and reading.